I am Dr. Abhilash Anthony, consultant urologist in Chaithanya Hospital, Kannur, Kerala. Today, I will bring you a newer technique of doing thulium laser enucleation of prostate. We have, over the course of 5 years, done around 2000 THUFLEP surgeries. And what we have encountered initially was the problems of incontinence, that is postoperative incontinence, stress incontinence, which usually lasts for 2 to 3 months. But then all of them recover, and we were happy with the technique. But over the course of years, we have come out with a newer technique which will give you an immediate postoperative second day complete continence. So that is a very good advantage of this newer technique. Another deficiency we have seen in the old technique is the amount of residual tissue which we have encountered. That is, after doing a postoperative ultrasound on the weeks follow-up, we see that a lot of residual tissue remains. Now with the newer technique, we see a complete resection is possible in the postoperative ultrasound follow-ups. Now, regarding the instruments, we use the IPG settings of 1.5 joules and 40 hertz, that will give the 60 watts. You can use 1 joule also. For coagulation, we use 0.3 and 100. IPG machine is good for doing thulium laser enucleation of prostate. We use the 1000 micron fibers. Why we use the 1000 micron? Because that gives less of vibration during the prostate surgery. Also, the 1000 micron fiber lasts a very long time. That's why it's quite economical that we can use 1000 fiber. Now coming to the technique of doing the thulium laser enucleation, is in the initial time what we used to do, we used to have the trilobar technique, we used to have the bilobar technique, we used to have bladder neck incisions first, we used to have start from the we used to make 2 incisions up to the veru and then resect the medial lobe and then go laterally like that. Now after a lot of cases, what we have come to a single fixed technique of complete enucleation, or the donor technique, complete enucleation in one sitting, one piece. So how it is achieved? So in the enucleation itself, in the initial days, what we used to do was you make an incision in front of the veru, come back to the area of the prostate, edge of the prostate. So by that technique, what we use is the mucosa from the level of the veru till the level of the edge of the prostate. We lose that amount of mucosa. That is the mucosa that is giving postoperative continence. Now with the newer technique, we are able to preserve the mucosa. So that is in the newer technique. If this is the veru, okay, what we do is we make an incision in front of the veru and you extend this incision through into the mucosa. That the incision is only through the mucosa, and that is extended till 12 o'clock position. So you extend the incision till 12 o'clock position. That is only the mucosa is cut, and you have to be very superficial. You cut it from a distance. The moment the laser fiber is touching the prostate, then the extra prostatic tissue, they are the sphincter area. The sphincter area gets damaged. So you take care that you don't touch the prostatic tissue. You keep a safe distance and cut the mucosa only in front of the veru, all through the 12 o'clock position. So now the mucosa gets separated from the rest of the prostate, and that mucosa retracts back. So that mucosa is saved. That mucosa gives the continence that we require in the postoperative period. Now from here, how to enter the adenoma plane? From this mucosa, what you do is you cut halfway through the veru, half distance through the veru you can cut, and then what you see is you see a bit of mucosa, a strip of mucosa in the right angle area. So what you do is, with the beak of the resectoscope, you mechanically remove or strip the mucosa from the prostatic adenoma, and you enter into this plane. Here, if you can enucleate or vaporize a little bit of tissue, you can easily enter into the adenoma plane. Once you are into the adenoma plane, you can a little more or a 2 or 3 millimeter more of or vaporization will give you the extra adenoma or the prostate, maybe the peripheral zone. You can get into the peripheral zone of the prostate. So that will lead you, and each time you go advance at a plane. So the mucosa is stripped below. It is retracted. Once the mucosa is retracted, you can easily go into the adenoma or the extra adenoma plane, into peripheral zone plane. And as you enter and as you progress to the 12 o'clock position, you strip the mucosa mechanically all around, so that from the voluntary sphincter area, so this is the voluntary sphincter area, 1 centimeter length of the veru is remaining, and then again in the veru area also another 1 centimeter, so almost 2 centimeters of mucosa is preserved from the voluntary sphincter to the proximal area of the veru. This mucosa with a little bit of mucosa gives the continence. Now we can see the actual videos of the procedure.
This is the cystoscopy view, the veru, bulbar urethra, sphincter, and there is a little bit of median lobe. You see the kissing lateral lobes. You start with the incision of anterior to the veru. You can barely see the ejaculatory duct, but we don't go at that side. We don't mind the ejaculatory duct. Now you can see we just barely cut just the mucosa. Okay, on either side. So that is anterior, at the level of the anterior end of the veru. We will make a incision throughout the mucosa circumferential. You see, we don't go too close to the tissues, especially in 12 o'clock area. If you go too close to the tissues, you will injure the voluntary sphincter. You are doing on the right hand side of the patient. Again, only the mucosa is incised, and the mucosa is incised full depth, that is mucosa, submucosa reaching up to the prostatic tissue. Now our next step is to separate the already separated mucosa, incised mucosa, from the remaining prostatic tissue. So if you make this incision, para incision along the side of the veru, then only that mucosa can be separated easily. Now you can use a little mechanical force with the beak of the resectoscope and incise the stretched soft tissues. That will lead you to the adenoma plane. Adenoma plane is easy to reach, but then the result will be a little tissue remaining, especially around the veru area. Apical tissue will remain, and that will result in a reduction in the strain. Now at the veru, on the other side of the veru, you can go a little deeper. That will result in complete removal of the apical tissue. That will give you a significant improvement in the strain, as well as reduction of discomfort, postoperative discomforts, and better healing and better flow rates. You can leave the fibrous tissue for the patient so that the continence is a little higher, and you go in the adenoma or extra adenoma plane as you wish. We prefer the extra adenoma plane or the peripheral zone plane. Here it is very easy to miss the exact plane. You may leave a few nodules of the adenoma, but that is immaterial. Okay, now you can see on the right side there is a small nodule left behind. Either you can take it or you can leave it. There is not much of a problem. You can see that a small adenoma is spared. or else you can vaporize that tissue also when you are done with the procedure. We will do the same thing on the patient's right side. You go on the side of the veru and slightly stretch the tissue at the T junction and cut the stretched soft tissues so that you will reach the adenoma plane. Now you can proceed in the adenoma plane, or you can go a little deeper if you want complete removal of the tissues. This patient had a lot of chronic prostate like inflammatory changes, so it is always better to remove the prostate along almost the capsule level, so that his chronic prostatitis symptoms are reduced. You can clearly see that we are going in the peripheral zone plane here. It's almost the peripheral zone plane, and little small micro abscesses are also noted in this plane. We prefer this plane just because the postoperative symptoms are lesser. So always take care when you go up. There will be some mucosal bands remaining. You can mechanically stretch it with the tip of your resectoscope, and once the soft tissues are stretched, you can cut it with the laser. Here also you can see that a small adenoma is on the patient side, but don't bother much. You can vaporize it later on. Now we are at the 12 o'clock position on the right lobe. Here also you can stretch the posterior tissues with the beak, the sphincter area. You can stretch it, and then get the remaining tissue with the laser. So little by little you can progress here. You may take a little more time in this area, but then that will result in better continence rates. You may not be too fast here. Once you have gone through this area completely, now you will become a little more faster. As I already said, there is a lot of micro abscesses in this plane. So we want to give the patient a little more relief. That's why we go a little periphery plane. Now once we are through the sphincter area, now we will be a little more faster. At this time of the surgery, the return fluid may not be in a good flow. That is because all the return holes or the outer sheath holes are outside your drainage area. So if you take a little more time here, you may need to stop the procedure and drain the bladder once. Once you have created a little adequate space here, then the return will start to happen. So now we are almost through the sphincter area. Now you can be a little bit faster. Here also we can see the adenoma plane as well as the peripheral zone plane. There are a lot of micro abscesses seen. So when you have a chronic prostatitis changes, better to go outside the adenoma plane. Also you can see on the right side there is a small nodule. Either you can spare the nodule or you can fulgurize it, vaporize it, or you can take the nodule. if you go in the adenoma plane, you will be missing most of these nodules. Once you start going in the peripheral zone plane, then only you realize that so much of adenoma tissue is remaining. In the 12 o'clock area, there will always be a little mismatch between the two planes. So you can always come back and make sure that both planes are coinciding. So you can join the two planes from the left and right together. Always when you come back, you get a better orientation. So you always come back and see whether you are in the right plane or you have taken two different planes on two sides. Now you can notice that the speed has increased now. Here now this is the 12 o'clock position. Now this is almost the 2 o'clock, 3 o'clock position, and on this side it is the 11 o'clock, 10 o'clock, 9 o'clock position. Here if we keep the peripheral zone exactly, then we can reach the bladder. Or if we give a little tissue there on the patient side, then a little apical 12 o'clock tissue will be remaining. Once you have reached the 12 o'clock area and the apex, that is the bladder neck area, now our aim is to resect the bladder neck down as far as possible. Say on the left side of the patient around 5 o'clock area, so that you can separate the bladder neck area. Now you should know that we are cutting only the bladder neck area. A little behind in the mid area of the prostate we have not resected much, but at the bladder neck area we have gone up to the 5 o'clock position. Now you are coming back and dividing the bridges in between, bands in between. Now here also you can see the changes of the chronic prostatitis. Now you can see that patient side and the specimen side, that is the median lobe. Now we will do the same thing on the patient's right side. That is just hemostatic firings. Now we are cutting the bladder neck area. Here also you can delineate the bladder fibers or the bladder neck fibers from the prostatic tissue by the color of the tissues, and the charring, the black color will be more for the prostatic tissues. Now you have the median lobe, so that will be hanging over into the bladder. So you can cut into the median lobe. Now here also you can see a little bit of adenoma tissue is remaining on the patient side. You can take it, you can vaporize it, you can vaporize it like this, or you can cut it. Now the direction of the cutting will be like in a vertical plane, if you notice. because if you want to take the full amount of tissue, then taking it will be like scooping up from the posterior side, because always there will be tissue inside or underneath the bladder neck. So if you go from the posterior side, it will be very difficult to lift up these tissues. It may not be much of a problem if you are going in the adenoma plane, but if you are going in the extra-adenoma plane, then there is every chance of entering the seminal vesicle. It is not at all a problem. Entering seminal vesicle will never result in any problems. But then you can avoid it if you are coming from the side. So that is why in this area we plan to go from the sides. So we will be making sloping incisions progressively. So another band of tissue. We will be resecting these bands of tissues so that uniformly we will reach into the area. Now you can see that the tissue is touched by the side of the beak. So in this area you can always use the beak to stretch out the tissues, and enucleation can progress at the stretched mucosal areas. Now if you go in the adenoma plane, this tissues will not be resected. Once you are going in the extra adenoma plane, what you can see is we will have a area like the keel of a ship. So that is way beyond the adenoma. To reach this area, we will have to go from the sides rather than from the posterior approach. The posterior approach will result in subcapsular perforations, but if you go from the side, there will be no perforations. So we will make multiple vertical or almost vertical or sloping incisions. You can always touch the tissue with the beak. Now here you can see that we have reached the capsule area at the bladder neck. So what we do is we will take we will leave a slightly more tissue on the patient side. So that is the posterior area. Here also we are almost going through the capsular plane. Anytime you can perforate. But then we can detect these perforations at the impending perforation level, so that you can avoid that plane and you can leave a little more tissue. Here also you can see that a lot of microabscesses are there. So that is why we take all the more reason to go all the more periphery, so as not to leave any inflammatory tissues behind. Now you can approach into the 6 o'clock position from either side. Now once you reach this area of almost the area of the veru, you can lift the prostate tissue or the resected tissue with the beak and cut from below. As you can see, there will be always some disparity between the two planes we have made. The only thing is that you should join these two. We are almost at the peripheral zone of the plane, so you don't have to worry about the remaining tissues, but you have to worry a little bit about the capsule. We are approaching the bladder neck areas. Here also earlier we had come close to the capsule. Now we have left a little bit of tissue so that the capsule is spared. Here also what you can see is we are pulling or retracting with the beak of the resectoscope. Now you can see we will go inside the incised area, and again we will retract with the resectoscope, beak of the resectoscope, and then we will cut the, you can see almost an impending perforation, so we will give a little more tissues there. You don't have to worry about these perforations if you are going in the adenoma plane, but then postoperatively the patients may not get that much of a symptom relief because of the residual infectious tissues, infected tissues. Now our aim is to join multiple areas of bridges. We have to resect these multiple small bridges so that you can advance slowly. Again we are almost near the capsular plane. The dissection in this plane is a little more difficult than going in the adenoma plane, that we agree. Here also if you go a little deeper, you can go into the capsule. Now we are on the patient's left side. You can see another bridge there. So we cut the bridge, and that will take you to the plane we have already created in the bladder neck area. That was deepened up to 5 o'clock position. Now this is the mid part of the prostate. Now you can again see that there is an impending perforation, but then we'll just spare that area. We'll go a little deeper here. You can see that is almost the peripheral zone and the capsular plane. Now you can leave a little more tissue here. So likewise we are stretching with the beak of the resectoscope. Now you can see that there are two different planes, and we will just join the, or we'll take the bridges down to join these two planes on the left side and the right side. So it will be like a V-shaped tissue, and we will be cutting the V-shaped tissue remaining on either side. Now you can see that a little tissues remain. You can give a small traction with the beak of the resectoscope. you can continue cutting. Now we are almost at the impending perforation. We give a little more tissues to the patient. We'll just make our plane a little more superficial. So now we are at the mid part of the prostate in the posterior area. We have already completed the bladder neck area up to the 5 o'clock position. So 6 and 7 o'clock position of the bladder neck is remaining. Here you can give a little more tissues to the patient so as to avoid a perforation. So in the adenoma plane, if you are going, then this perforation may not be much of a problem, but then the residual tissue will be a problem. Now we have reached the bladder neck area. So we had done till 5 o'clock position. Now we are cutting into the median lobe, that is projecting into the bladder. So once you have done this much, then you have the option of going into the bladder and then looking at the median lobe from the side. Now you can see that we are looking into the bladder from the side, and we can easily take out the median lobe which is overhanging. We can easily see and divide the area at the bladder neck. So if there is a large overhanging median lobe, this would be a really good method. Now we had already reached a little more on the other side, if you remember. So we are in 2 planes, but then you don't worry about the different planes, because once we start joining both the planes, then you can easily resect the complete tissue. Now you can see that from either side we are seeing the end of the resection area. Here also you can see an impending perforation, so you leave a little more tissue to the patient. So in this method of resection, enucleation, there is a little more chance of perforations, but then the postoperative patient will be having a better symptomatic relief, especially when there is a lot of chronic prostatitis symptoms like dysuria. So that will give you a better alleviation of symptoms. Once the resection is complete, you go for the morcellation. Before that, you can check for the bleeding sites. If there are too much bleeding, you can always use a bipolar and do a complete hemostasis once again. If there is not much bleeding, you can go for the morcellation straight away. So to conclude, this patient had a chronic prostatitis changes in a medium-sized gland. So we had done an extra-adenoma plane and we have resected the prostate almost completely, so that all his residual symptoms, pro-irritative symptoms, are reduced. In the next video, we'll show how to do a large prostate with a huge medial lobe indenting into the bladder neck. Here you can see the mucosal flaps floating. It is these flaps that we want for a good continence. These flaps are the ones which gives the good continence. Now the morcellation is complete and we'll finish this case here. Thank you.